Well, let me move along and talk about diabetic meds. There's a lot of new stuff in here, so probably worth things. I don't know how many years sort of in arrears sort of they make the questions. I think it's like it takes like 2 years for the questions to percolate down. So hopefully all of the brand new diabetic meds probably may not show up there, but it's probably worth learning about them nonetheless. Um, Diabetes is a complex and pervasive disease everywhere. I mean, it's sort of at the simplest understanding. Your blood sugar is high, and it leads to all sorts of microvascular problems downstream in your heart, your kidneys, risk of stroke, risk of liver injury, risk of renal failure. So it's a multi-organ system disease. There's a variety of reasons for this, especially with type 2 diabetics, where we have increased glucose absorption, possibly due to increased dietary indiscretion, but also there's sort of an aging of our islet cells of our pancreas that goes on, and the pancreas islet cells kick out less and less insulin or are less responsive to glucose loads, even though they're still capable of normal functioning, they're not responding adequately to glucose loading. And there's probably some issues that occur in the liver as well, where the liver responds and produces excess glucose to a variety of hormonal and dietary changes. So any one of these sort of areas is sort of ripe for pharmaceutical intervention. And I think in recent years, we've come up with a handful of groups of drugs that act at each of these areas. I want to start with sort of the oldest oral medication, which is the biguanides, which there used to be when we go a mud pile or mud piles for acidosis. Some people think the P was fenformin, other people say paraldehyde. Fenformin really was a bad acidosis producer. It was removed from the market in 1978 after being on the market for almost 20 years for producing increasing numbers of severe lactic acidosis, even at therapeutic doses. Now, its close cousin, metformin, came along, which is still the number one first-line therapy for type 2 diabetes. It too can produce lactic acidosis, but it's usually in the setting of poor renal clearance that makes it accumulate or massive ingestions where people take so much of it. So it's a dose-dependent lactic acidosis, and you just have to get enough metformin in your system, whereas taking it regularly at regular rates, rare cases of lactic acidosis happen. The number I always hear is 1 in 300,000 is about the incidence of lactic acidosis or MALA, metformin associated lactic acidosis, which is relatively rare. The trade name, and you won't be given trade names, mind you, is glucophage or glucophage XR. The way it works is it decreases hepatic glucose production, so you're not as stimulated to make glucose with your diet, so decreased gluconeogenesis. It actually decreases some absorption of glucose in the GI tract, but not a lot, and does increase insulin sensitivity, thereby increasing peripheral glucose uptake, but not so much so that you would get hypoglycemic from taking these. Now, in severe multi-pill ingestions, you can in fact get hypoglycemic, but often it's also in the phase of severe lactic acidosis and maybe even multi-organ system affecting. The immediate release tablet peaks in 3 hours, a half-life 6+ hours. The extended release lasts all day, so that is longer. Our general approach to these are to monitor them for lactic acidosis if they can get a lactate easily, or anion gap if they can't. But a big warning is literally every other drug we're going to talk about has a combination agent that has metformin in it. It seems like metformin is the drug you start with, and if that's not working, you can try drugs from the 3 or 4 other classes that are out there. And some of them have names that make you think it's a drug that acts on glucose, like glucovance, or some of them have names that like is just puzzling, like what is Genta Duetto, which I've never heard of, but it's out there. So these drugs are have to look up and see what's in them. A lot of them are combo medications with metformin. So, as I mentioned, if someone comes in, I would hydrate them, I would check their electrolytes, I would check their anion gap, and I would check their lactate level both on presentation and probably 4 to 6 hours later. If the lactate level is rising, especially if it's in the teens, then they're sick enough to certainly need to be admitted. The big question is when do you offer hemodialysis? Um, the X-trip guidelines talk about lactates greater than 20, but in our experience, by the time you wait for that to happen, they're usually really sick and may not tolerate hemodialysis well. My preference is to start hemodialysis while they're not so sick that they can actually get to both the lactate and the metformin removed and not be inhibited by the fact that they're also hypotensive, therefore making the people who are doing hemodialysis nervous about putting them on the machine in the first place. But if lactate levels aren't available, I say a pH less than 7 is always a good reason for hemodialysis, almost irregardless of the cause of the acidosis. So here's your simplified uh, pyruvate lactate chain. Glucose goes to pyruvate, which is interchangeable with NAD to NADH to lactate. Which is then pyruvate, if it's working okay, is fed in to the citric acid cycle. Unfortunately, metformin forces everything to the lactate side. So it's not an ischemic lactic acidosis. It's not a hypoxic lactic acidosis. It's a chemical lactic acidosis that's caused by shunting through pyruvate to the lactate. They have some side effects, which sometimes makes them intolerable. People have GI symptoms. They recommend taking it with food. It has a metallic taste, which may decrease PO intake, which some people don't tolerate very well, but that in and of itself with the GI symptoms may lead to some weight loss, although not as profound as what some of the other drugs we'll talk about. Alcohol use, not necessarily alcoholism, may increase the likelihood of lactic acidosis, mostly through probably coenzyme vitamin deficiencies necessary for that pyruvate lactate conversion. The good news, however, is in inadvertent double dosing and inadvertent pediatric cases, it doesn't cause hypoglycemia. So the person who took 2 of these, who was otherwise, besides their diabetes, normal, can probably be watched at home. The toddler who gets into their caregivers, metformin could be watched at home. They probably can offer regular food and drink. They won't get hypoglycemic. There's some cautions in renal failure, probably not a good drug for people with profound renal failure. Other diabetic agents, unfortunately, a lot of them are renal dependent. Sometimes you just have to go to insulin at that point. The black box warning exists, and they tell you to notify your doctor if you have malaise, myalgia, hyperventilation, somnolence, and et cetera, which are all vague, sometimes symptoms. So anybody who feels, quote, icky while they're taking metformin may be reasonable to send in to get some electrolytes and lactic acid checked. Don't use them in renal disease. Don't use them for diabetic ketoacidosis. And don't use them in heart failure or liver failure. Matt Correa, mostly, and myself did a study what is the best way to get metformin out, whether it's hemodialysis or CRRT. I doubt you'll be tested on this, but sort of the brief sort of punchline is the mortality is, or sorry, the survival rate is about 84%, meaning the mortality rate's about 15%, no matter which modality you have. So both of those seem to work okay. So if they can't do dialysis, CRRT is an option. So the other drugs that have 3 generations are the sulfonylureas. I would say these are used less and less so these days. Wind the clock back 20, 30 years, and these were the first line agents before metformin became much more popular. Unfortunately, with these drugs, you get stimulation of insulin release from the pancreas, and so they are very high risk of having hypoglycemia. So often people who take these drugs also have to monitor their blood sugar. Sort of the nicety, if you will, with metformin is if someone doesn't want to do finger sticks and monitor their blood sugar, except in the lab periodically, you can treat them with metformin. With sulfonylureas, less so. Most of the first generation products, and again, you'll get the generic names for these, aren't on the market anymore. So the one that may still be around and may get tested on is chlorpropamide. And I know that sounds similar to other chlorinated drugs like chlorpromazine, which is a antipsychotic medication, but it's chlorpropamide is Diobanase. The second generation, which are in common use now, are the ones like glipizide and glyburide, and because they have glic and gly in their name, makes you think they're a glucose monitoring drug. The third generation is around, doesn't have a lot of advantage of the second generation. It's glimepiride. These are the drugs and the doses. They all stimulate insulin release, and they all work by binding to this ATP sensitive potassium receptor, inhibiting a potassium receptor that therefore opens up a calcium channel. So they may give you a couple of choices for how do they work, where they open the potassium channel or open the calcium channel or block the potassium channel, or, the answer is they block potassium, open calcium. I don't know a good mnemonic for remembering that. If someone has one, let me know. I'll include it to my next version of this lecture. But here's a little diagram of what that means. There's this potassium channel that is what your islet cells react to when glucose rises. So when that's closed, it won't respond to the glucose stimulation, which would then open up the calcium channel, which would then release insulin. This will only work if you have somewhat intact islet cells, which means you're a type 2 diabetic, usually earlier in the course than later, because over time you do lose sensitivity to your islet cells. Or what we usually find is the child who has a completely normal pancreas takes an adult's sulfonylurea and they're profoundly hypoglycemic. And those are the ones that we need to monitor. And we do have an antidote for that. So, of course, anything as an antidote is testable. These are from, I think, our own policies. And by the way, I think our policies for all the diabetic meds are pretty well written. So if you want to study review, those are good ones to look at. I don't think anyone's going to ask you what the half-lives of or peak of actions are. But in general, most of these drugs peak within 2 to 3 hours and they last a whole day. So they do last a long time. So hypoglycemia is the big problem. The downside of these drugs is they often are associated with weight gain, which is often not what we want with diabetics. You do get some epigastric fullness, so maybe that decreases some intake. But one of these, glyburide especially, can cause a disulfiram-like reaction. So that's sort of a unique thing that could be asked about, question on with glyburide. The glucose lowering effects are pretty quick. So if a kid ate a couple of these, it's probably worth checking them out in a half hour to an hour when the drug should be peaking. And if the child is acting sleepy, then they need to go in. A lot of places, and I think for a test answer, is almost all of these single pill ingestions are sent to the hospital. I think that is the generic standard of care. However, I think there's room in certain cases, especially if there's glucose testing at home and a competent adult with them, where you could possibly evaluate them for the first hour at home to see if they actually got into it by are they getting hypoglycemic, if the parents are willing to test them, or at least if the kid's getting symptomatic. So we do a little bit different here. So, but the right answer on a test and nationally is they all get sent in for evaluation. They're not used in children, at least by design, but most children aren't type 2 diabetics. Conservative dosing if there's renal or kidney or hepatic issues. They can at times cause a syndrome of inappropriate antidiuresis, so they can have volume retention, which sometimes makes heart failure worse and sometimes makes them have low sodiums. And you don't want to use these in type 1 diabetics who have ketoacidosis or in pregnancy. There's a sort of subgroup of insulin secretagogues, which I almost never seen used. I mean, maybe they're around a little bit. The idea behind these are they were going to kick out a lot of insulin by the same mechanism of action as the sulfonylureas, but they're really fast on and relatively wear off pretty quickly. So the idea is if you eat a meal, you can take one of these with each meal, and it would kick out the appropriate amount of insulin with the meal that at least sensitize your islet cells to work better in response to the glucose carbohydrate loading that happens with the meal. I would treat these just the same as sulfonylureas by setting them all in, by getting glucose checked for the risk of hypoglycemia. The treatment is, interestingly, octreotide. It's a somatostatin analog. It actually blocks the calcium channel on the pancreatic beta islet cells, thereby closing it down so all the glucose in the world will not make that islet cell secrete insulin. It essentially is it's like an on-off switch for the islet cell. A little bit of octreotide, and it is relatively small doses, will turn off the islet cell for 6 to 8 hours. So it's a simple double dosing kind of situation. Usually one dose is more than enough. If someone took a bottle full of either of these medication classes, they probably would need at least get treated for 24 hours. So 3 to 4 or more doses until they're demonstrated to be normal glycemic for 12 hours after the last shot of octreotide. Doses won't be asked, but there they are for your information. Now, octreotide also comes in much larger amounts. So even though the doses may not be asked, there are 1,000 milligram per 5 cc's and 5,000 micrograms per 5 cc's. Even though it says for subcutaneous injection, these are often used for bleeding esophageal varices as a constant infusion. These are not the octreotide that you want to reach for or the ones you accidentally want to click on the Epic drop-down menu for ordering. It's small amounts, 50 micrograms sub-Q. If they're starting to mix it up to give it IV, they have chosen the wrong quantity or the wrong dose and the wrong route by which to give it. So let's get to some other agents. I'll talk about these because they are injectable. And although people have been talking about Ozempic for the last several months or years or so as sort of the miracle drug that helps diabetes and makes you lose weight, there are other drugs in the same class that are GLP-1 agonistic agents. The original ones had to be used sometimes twice daily or once daily. So injecting yourself once daily probably was not more appealing to people than insulin was, and most of the people probably preferred insulin than these drugs, although these drugs are less likely to cause hypoglycemia. The first once-a-week drug that was available was exenatide, followed quickly by dulaglutide or Trulicity, which actually was widely prescribed at the time a few years ago. But the one that sort of was the breakthrough drug, and it's always unusual why the third or fourth or fifth version of a molecule is the one that makes the market share. But semaglutide or Ozempic is the one that is now the once weekly titratable, long-acting GLP-1 agent. Now, interestingly, both it and its cousin tirzepatide, which also came out this year, which I doubt you'll get asked for because it's just too new, they have different names for what they're used for. So the lower doses, for instance, with Ozempic is indicated for diabetes, and you can only prescribe it for diabetics if you patient or whatever wants to get it covered by their insurance, and it goes from a half up to 2 milligram amounts once a week. The Wegovy for weight loss has to be either proven or and very few insurance companies do it. So if you prescribe that, it has doses in the same range as Ozempic, but also goes up as high as 2.4 milligrams once a week. It in overdoses, it mainly has GI side effects and may have some pancreatitis. In general, I think most people can be watched at home to see if any of those will happen because they don't happen uniformly if they overinject themselves. It's pretty hard to dial the pen up too high to give yourself an injection, but we've had a few calls, so it does happen. The new one, which is Manjaro, and again, I won't use trade names, and Zepbound similarly have doses ranges for both diabetes and Zeparo and restriction on prescribing. What makes this one different is in addition to being a GLP-1 or glucagon-like peptide 1 agonist, it's also a GIP or glucose-dependent insulotropic polypeptide agonist. I don't know if either of those are testable, but this is kind of what they do. There's overlapping things. Both of these sort of work on both the liver and the GI tract. They decrease insulin sensitivity, decrease insulin secretion, decrease beta cell proliferation, but mostly they cause decreased appetite, increased satiety, decreased gastrointestinal motility, and sort of the full feeling that people have. A downstream effect of this is actually improves hepatic function, and one of these is being investigated for non-alcoholic steatosis because it improves liver function in people who have fattier livers. So you're going to see more and more of these out there. One of these was just approved because it actually helps with heart failure and longevity as well. Now, there is one that's oral. It's just not out there very much. It's the same drug, semaglutide. Has the reason it's not available orally is the bioavailability is like 1/100th of the subcutaneous bioavailability. So the doses of the brand name Rybelsus, which is semaglutide, is 3 milligrams, 7 milligrams, and 14 milligrams, as opposed to a half a milligram of Ozempic. And you need to take that every day, not once a week. So you can see 14 times 7 is how much you take per week as opposed to 1 milligram a week. So the bioavailability is different. All of them produce pancreatitis. Sometimes it's usually mild, but some have been severe. People who have GI symptoms, abdominal pain, nausea, vomiting should go in to be evaluated and stop using it. The other interesting thing about these, which has been seen with people having elective surgery, they're usually told to fast from midnight until their surgery. Some of them don't empty their stomach and so have full stomachs and have vomited or aspirated as a result of the once a week injected semaglutide that basically decreases their GI motility and leaves them with that full feeling, which they are full because there's still stuff in their stomach. A similar medication that's taken orally are the group of drugs called the gliptins. I think there's three of these available on the market. One of them is mixed with metformin, of course, like everything else is. These basically inhibit the breakdown of the GLP-1. So it's sort of a post-enzymatic inhibition rather than just GLP-1 agonism. But all the side effects are pretty much the same. It increases the sense of fullness, it decreases GI motility, it decreases circulating glucagon. These are from our thing for the different, I guess there are 4 of them out there with different names. They all end in gliptin. So glucose is in, or glip is in the name. They all peak within 1 to 4 hours, and they all last pretty much all day long. The long-acting one, the long-duration one is linagliptin. I'm not sure how they would work that into a question, but it's just sort of an oddity of its pharmacology. Every single one of these have been co-branded and co-released with metformin. So always ask about metformin. And they have some strange names that make no sense as far as anything that would have to do with glucose control. So the side effects, this is one that can cause hypoglycemia from time to time, although not uniformly. It's mostly a reduction in postprandial serum glucose for about an hour or so. They can have pancreatitis. And this one also has a risk of Stevens-Johnson syndrome. Probably not a good drug for people with severe impaired renal impairment. And have to be careful, the older people, as they have age-related renal injury. The next drug, and these are also pretty widely out there on the market, are the flozins. All of their names end in flozin, canagliflozin, dapagliflozin, etragliflozin, and pagliflozin. So it's sort of a gliflozin, but we just tend to call them the flozins. They're also, of course, co-branded with metformin and sometimes other drugs like a gliptin and a flozin together. So it all makes everything complicated. These are sodium glucose transport inhibitors. And basically, the way these work is they make you urinate out a lot of sodium and a lot of glucose with it. So they have this urine that's just loaded with glucose. And that leads to at least one of the side effects. So while you can get hypoglycemia with these drugs in isolation, you also can get a significant volume depletion from a sort of osmotic diuresis that occurs with it, and sometimes to the point where it's causing sort of a post-renal acute kidney injury due to excessive diuresis. They're also, with that diuresis, losing other essential elements like potassium, magnesium, and phosphate. So some of these people need all of those checked, and they may be at risk for or abnormalities associated with those metabolic disorders. There is a bigger risk for these, which is important and is testable and is real. The FDA has issued warning about these can cause ketoacidosis, sometimes called euglycemic ketoacidosis or normal glycemic ketoacidosis, because unlike type 1 diabetic ketoacidosis, who often have sugars in the 800 to 1,000 range, these folks have blood glucoses in the 200 to 300 range. So not quite normal glycemic, but not off the charts glycemic. These often happen in the first several weeks after starting these drugs, although it really can happen at any time. It tends to occur often with elevated blood sugars less than 200, so not terribly outside of the normal range. However, all ketosis needs to be treated with saline infusions and insulin infusions. And because their blood sugars are initially low, they often paradoxically need glucose infusions. So it's sort of like treating the diabetic ketoacidosis after the first phase of diabetic ketoacidosis treatment. Once their sugar normalizes, but their ketones haven't cleared, it's the same therapy, volume resuscitation, low dose insulin to clear the ketosis, and sugar so you don't make someone hypoglycemic while you're giving them insulin. They have been associated with some increased risk of infections, both cellulitis of the legs, but more notoriously Fournier's gangrene. This is the report of 55 cases of Fournier's gangrene in patients taking these group of medications. Some of them died, some of them were septic. Many of them needed surgery, like fecal diversion surgery, which means they needed an ostomy for them so they wouldn't soil on the Fournier's gangrene, which is gangrene of the perineum, the area between the rectum and the genitals. Is sometimes is a hard place to investigate, and if your doctor doesn't completely strip you down and look there, then that can sometimes be missed or overlooked when you come in for a checkup. But usually it's painful, so people will complain of pain in that area. A couple of other drugs just to round out the list, and I know it gets complicated because we're on the fourth or fifth drugs for diabetes. If I was going to not remember a group, this would be the group I wouldn't remember. The glitazones, one of them's off the market. One of them still is on the market, but under a REMS system, risk evaluation and mitigation strategy. It's occasionally used as PO glitazone. The problem with these are they increase a heart failure risk. They bind to PPAR, this peroxisome proliferative activator receptor, lowers free fatty acids and adipose tissue, and assists glucose sensitivity in muscle. So they don't really cause hypoglycemia, but they do help with diabetes management. The problem is there's a significant risk of weight gain, which is all related to fluid retention. So people have congestive heart failure or peripheral edema. These are terrible drugs to go on. And because of the risk of that and people dying of worsening heart failure, several of the original versions of this have been taken off the market. So that's the one sort of buzzword association with the glitazones. Black box warning about heart failure, increased risk of liver function, although some of that may be passive hepatic congestion from heart failure, and it's a pregnancy class C. So don't use it in heart failure. I don't know how many times I can say that. If you have class 3 or 4 heart failure, which is usually pretty severe, these are not the drugs to take. There's another drug, which isn't a group of drugs, which isn't used very much. They're kind of like starch blockers. They help you digest starches actually, so they don't really block it, but they just basically turn your starch into more metabolically helpful forms of starch in your diet. I haven't really seen people on either of these drugs in over a decade. They're essentially zero risk for hypoglycemia because they don't really do anything with insulin. They all work at the level of absorption. So as far as these medications and what we worry about, the big risk is for hypoglycemia are the ones that stimulate beta cells, sulfonylureas and the metaglutides, a little bit with the thioliidines that increase sensitization. But metformin, the association is with lactic acidosis, and with the flozins, the association is with normal or near normal glycemic ketoacidosis. The rest of them are generally well tolerated. So any questions there? I have a couple of slides about insulin. I'm just going to show this one. And the slide sets in the thing is the longer acting ones tend to not have peaks that cause hypoglycemia, but we have once they take too much of it, we may have to watch them for long periods of time. So let me go back to the chat box, and someone just asked something. Crushed and injected evidence, the last one. Your thoughts about keeping asymptomatic patients NPO? Oh, I don't really think that's necessary. I think almost all of these folks, no matter which version of things they may have double dosed or extra dosed on, or even intentional ones are always going to go in. But the double extra dosing took someone else's meds. I think it's fine to eat. There's no reason to keep them NPO. Yeah, I know. It doesn't seem very good. And certainly for kids, it's like torture. If some kid gets into grandma's sulfonylurea, you don't want to starve them. You want to actually give them sure, food, carbohydrate. I would feed them a peanut butter sandwich or something that they like and let them have simple and complex carbohydrates so their sulfonylurea can work on kind of thing. So I avoid giving them both doses of either octreotide or dextrose. All right. Do we need a break before we get into pesticides, or should we just keep going? About a Okay, quick break. 5-minute break. We will start at 5 to the hour, 5 minutes to 2. Be back with pesticides.